Welcome, everyone, to the first general meeting of the Silicon Valley Democratic Club of 2021 under our new president. I would like to first remind everyone that this meeting is recorded. If you do not wish to be recorded, please turn off your video and mute yourself. We just record it to share with our members who are unable to attend. And today we really have just one agenda item, which is a topic that I think is on everybody's mind around the COVID-19 pandemic. And with us today, we have Stephanie Moody-Geissler. She has her master's in public health from Columbia University in epidemiology and global health. And for the past decade, she has been working in infectious disease surveillance, prevention, and control from mosquito-borne diseases in Florida to Ebola in West Africa. She's been working in hospital infection prevention since the start of the COVID-19 pandemic. And I think that that may be one of the most modest biographies that I've seen. I know that her interest in infectious disease goes well beyond a decade. I first met Stephanie over 15 years ago, working on grassroots initiatives to address the HIV pandemic. And I know when I met her back then that she had already shown a passion and interest in infectious disease for a very long time. So I'm really grateful to have her with us today. She's not only an expert in the field, and this is the field that I think most of us are interested in, epidemiology specifically, to really understand how the pandemic is spreading. But she's also an excellent science communicator. She has her own podcast, the Pump Handle Podcast, which is a great name for an infectious disease podcast. So I'm glad to have her here, and I'm going to go ahead and turn it over to her so she can start with a presentation. I think it's maybe 20 minutes, and then we can do a discussion period afterwards.
Great. Thank you so much for the introduction, Jenny. Yeah, we've known each other for, I didn't want to think about it, but yeah, a decade and a half. Time flies. So I am going to share my screen now. Okay, does everyone see the presentation mode? Okay, hopefully you do.
Yep, we see it.
Okay, great. So I'm going to get started. So this is kind of just tried to keep it fairly high level. Didn't want to get too down into the weeds. If there is anything that I'm not explaining well, or you'd like me to go over in a different way, stop me in the middle of the presentation, be like, I didn't understand what you said, or else I'm going to keep rambling. And if not, at the end, we can have an open discussion. So first off, I am an epidemiologist, and I'm a second-year medical student right now. I am not an immunologist, and I am not a virologist. So if you want to know super specifics about, you know, the specific gene of a certain variant that we're seeing, I'm not going to be able to answer that. But I will try to the best of my ability to answer what questions you do have. So let's get started. So you've seen all these graphs. There are dozens of websites right now that have good data that are showing what we have right now on the number of cases and the number of deaths that we're seeing around the world and in the US. Of course, we all know, unfortunately, that the US is carrying the heaviest disease burden right now that we have been able to count. We made the unfortunate pass of over 400,000 deaths last week, and over the weekend, 25 million cases of COVID-19 in the past year of the pandemic. The two other graphs that you see over on your right are from Brazil and India, the two closest nations to our case count. And they're at 10 and 8 million. They are 15, 8 million. They are so far less than us. We are definitely carrying most of the world's disease burden right now. I'm not going to bore you with a ton of these types of graphs because I'm sure that you've all seen them ad nauseum. Like I said, there's plenty of good websites out there if you really just want numbers like that. I wanted to show you this particular website and visualization of the data, though. This is from the Harvard Global Epidemics website, because this gives a slight different sense of the current pandemic in the United States. We all know the case counts per state, per county, but what I want people to think about is not just the pure numbers of cases, but the cases per 100,000 population of a certain area. You can't compare just based on numbers, the number of cases or deaths in New York versus California versus Florida. Yes, each case, each death represents a person. But if you want to compare the disease burden and the trending data, you have to look at cases per 100,000. It equals it out based on population. So as you can see on the screen right now, Arizona has the heaviest burden right now based on population, followed by South Carolina. California is actually a little bit farther down. Florida actually isn't even on this list right now as a state. So there's so many different ways that you can think of the data that's not manipulative. It's just a different method of looking at the data. So I just wanted to put this out there so that you can think about data differently. One of the things that I wanted to get into real quick was the unequal distribution of COVID disease burden in the United States. And that is based on race, ethnicity, and income. We've read the news stories. We know it's there, but what does it really look like? If we go on the CDC's website, you can see down here that overall the hospital rates, again, per 100,000 population, if we use whites as the baseline, the reference point, we see that Native Americans and Alaska Natives have a rate of 3 times that of whites. We got non-Hispanic Blacks, again, 3 times. Hispanics, 3 times. Even non-Hispanic Asian Pacific Islanders are a little higher than whites. There is clearly a disproportionate burden on non-white Americans. Previous slide was about hospitalizations. Looking at deaths, again, per 100,000 based on the population of that race or ethnicity. This shows us that Black individuals in the United States are dying at a much higher rate than whites. Everyone else is too, Native Americans, Hispanic, Latino. But also, you can't just look at it nationally. Got to go down further, looking at the state levels. You see in California, over here, looking at race and ethnicity, Hispanics actually have a much higher disease case burden. But then you go and look over here in New Mexico, and it's the Native Americans. District of Columbia, Washington, D.C., it's African Americans. So when, I know most of you probably understand and know this already, but America isn't one entity. We have our individual states, we have our counties. We have to really drill down into data and into population data to truly understand where the disease burden lies and who bears it at each level, each administrative level in the United States, because it's very different. This was a study in JAMA a little bit ago, again, showing us that race and ethnicity of COVID is a heavier burden on non-whites. This specifically is looking at MIS-C in children. Some of us may have heard about MIS-C a while ago at the very beginning of the pandemic. It is a condition mostly found in children where multiple parts of the body are inflamed. And this study out of New York shows that Black and Hispanic children not only have higher rates of hospitalization, but also MIS-C that is disproportionate to the population that they make up in the city. There needs to be additional studies to exactly look at why that's happening, to understand what particular impact of health disparities and structural racism play on that. But it's another example very clearly. This was a very interesting study that came out in, again, JAMA a little bit ago, showing us that besides race and ethnicity, we also need to look at income inequality, both together with race and separate. I'm going to try not to read it off the slide, but you can see here that with an increase in population in a particular county, for Black and Hispanic, we see a rise of infection and deaths. Separately, we see that income inequality is also related to an increase of infections and deaths. The quote from the paper, high levels of income inequality harm population health, irrespective of race and ethnic composition. So when we think about race and ethnicity and disparities, we also need to think about low-income Americans separately from race and ethnicity. It's something that usually goes together in a lot of people's minds, whether that's people's own biases or based in fact, but it is something that we need to consider separately. Why are we seeing all of this? We're seeing this because essential workers. We're seeing this because low-income workers, more contact with the public, higher chance of infection. We're seeing this because of access to healthcare. Low-income individuals might not have insurance, can't afford insurance out of pocket. They may have more acute chronic health issues, which we all know puts them at a higher risk for COVID-19 infection and death. A lot of low-income workers don't have paid time off, sick leave. If they're sick, they got to go into work. There's also density of living areas. There is chronic and toxic stress that is generational, that is based on systemic racism and discrimination. And then there's other factors that aren't on this page and that a lot of sociologists, social epidemiologists are going to be exploring. The pandemic is going to make up a lot of dissertations for the next couple of decades. There is a lot to drill down into. Whoop. Hi, Teresa. Oh, okay. So I was asked specifically to look at the disparities in the United States, and that's what we have so far. We clearly have a disparity. We have the numbers. Some papers are starting to look at it. We all have our suspicions of what's going on, but it's going to take a lot more effort and work to really dig down into it. We all know that there's a lot of systemic racism and discrimination and income inequality in the United States. And this pandemic is making it shine through so brightly that it can't be ignored anymore, period. I am hoping that with the new administration that we can start to address some of these issues, not just for the pandemic, but for the health and well-being of America and Americans in general. We'll see how that ends up. was also asked to look at the United States compared to other countries. So I picked a few others to look at and compare how we have handled it versus how the other countries have handled it. I wanted to show you all this chart. This is from the Johns Hopkins board that probably a lot of you have visited. This currently is a range showing deaths per 100,000 population. Again, as you can see, it's a different way of looking at the data. The United States is halfway right now in this chart right here. We have a fairly high case count compared to all of these other countries. However, small countries with small populations, they have a huge burden of disease right now within their population. This is going to deeply impact them. I ended this right here on Sweden because I did not have a slide specifically on Sweden, but I wanted to talk about them briefly. I'm sure that a lot of us remember conservatives, Republicans in the House and the Senate earlier in the pandemic saying, we don't need lockdowns, we don't need restrictions. Look at Sweden, they're not doing any of that and they're fine. Well, they actually weren't. If you look at the numbers, they weren't that whole time. They have an incredibly high death rate in their elderly population. And they started actually doing more strict measures during the fall rise. They were rising just like the rest of us in Europe and in the United States with case counts and loads. And it was a misconception by a lot of people that Sweden didn't have any restrictions. They did. They weren't very strict and they weren't necessarily enforced, but they asked people, don't go to restaurants in large groups, don't crowd areas, et cetera, et cetera. And the reason why it wasn't, emergency orders or anything like that, they have a slightly higher respect for science and listening to their government and listening to requests and science coming from the government. Also, Sweden has universal health care. Sweden has guaranteed paid sick leave, even for McDonald's workers. So if an essential low-wage worker was ill, they could stay home. That helped keep some of the earlier case counts down a little bit in that country. Those are things that we do not have here in America. So when you see politicians or your crazy neighbor down the street posting on Facebook trying to compare countries and saying, well, they're doing this and we're doing this and they're doing much better, you have to look at their society. What are they offering that we're not, that could account for the disparities in the caseload, in the disease burden? So just wanted to briefly mention Sweden. I wanted to throw this up here. I'm sure a lot of you have seen it on social media. This is the Swiss cheese model. It is a visualization of concepts in epidemiology and public health that we all should be familiar with right now. You can't just have one prevention strategy. You have to have multiple prevention strategies because none of them are 100% guaranteed. So in the Swiss cheese model, there's going to be little holes in each prevention strategy. Things are going to get through, but you stack up enough prevention strategies, and hopefully by the time you get to the end, it's so small that it won't have a huge impact. So first country I want to talk about after Sweden is New Zealand. New Zealand is a wonderful case study to look at. It's an island, so that helps them out, but they have done an excellent job with non-pharmacological interventions into their study, into their pandemic control. You can see here on the slide, I have a lot of things listed, but just to rattle them off real quick. They quickly instituted quarantine and testing for all arrivals, mandatory government facilities, They quickly did a registry for PPE right off the bat. They did a public partnership to get COVID tests up in real quick, even higher than South Korea, which did an excellent job universally testing their population. They had national contact tracing protocols to identify every contact of every case they got. The United States fell very flat on that. And in March, they were one of the first to institute a very incredibly strict lockdown that lasted over a month. Only way you were allowed out of your house was for going essential things like going to a grocery store or emergency medical care. New Zealand has been a shining example of how we should have handled it and how we didn't. They unfortunately did just yesterday report their first community case in the first 2 months, but I have no doubt that with the amazing protocols that New Zealand has in place, that they will once again be able to control any spread of COVID-19 that has been reintroduced into the population. These are just a couple graphs from a Lancet article showing the epidemiological curve of cases and putting the measures that they had in here. Another thing that they did is they tested asymptomatic populations in case clusters. For a long time in the US, we decided, oh, if you're not sick, you don't need to get tested. No, you do. Luckily, New Zealand decided right off the bat, hey, we gotta test everybody. Another example case I wanted to go over was Hong Kong. Hong Kong, again, island, kind of self-contained, but they did similar things. They did not have a lockdown until recently. However, they had fairly strict social distancing protocols. They did not have a mask mandate, but they had already a fairly high mask wearing rate. As you can see here in the graph, early on in January, it was already to 3/4 of the population, and it just rose from there. There is something very interesting about Hong Kong that I want to mention, though, is that you can see down here with the red arrow that there was flexible work at home arrangements. And, the cases are small. And then when that ends, all of a sudden you see a case increase. And mask wearing didn't change very much right then. It was about the social distancing, the working from home. That's what changed their case count. Again, Swiss cheese model, you need all the things. Right now in Hong Kong, a particular neighborhood just went into lockdown. It's the first time anybody in Hong Kong has gone into lockdown. During the next couple of days, the government is going to test every single person in that neighborhood. That is really good technique to see how prevalent the virus is in the population, to properly quarantine and isolate individuals to hopefully stop a huge cluster from happening. Another thing that we just aren't doing in the United States. You can see right there, there's the graph. I want to kind of end this. I know I'm already a little over time, but I kind of wanted to end this on vaccines. I didn't prepare a lot of slides about vaccines because everything keeps changing so fast. Even this weekend, a ton of things changed with the variants and with the vaccines. So I kind of want to leave the vaccines more open to questions and a back and forth discussion. But right now in the United States, hopefully you're well aware that we have 2 vaccines that have emergency use authorization from the FDA, Moderna and Pfizer. They're both around 95% effective. They both require 2 vaccines in the series. That's me up there in the corner. That's on Inauguration Day, actually. I got my 2nd Moderna vaccine. Very lucky to have that, considering I'm a younger, relatively healthy individual, but I work at a hospital, and my hospital was fortunate enough to get enough vaccine for every single employee, from the COVID nurses to the lunch lady in the cafeteria. And I thought that was very important that it was opened to all employees, because we can't, if we want to get a handle on this disease, every single person needs to get vaccinated that can get vaccinated. If it is offered to you, you need to take it. I know there's been a lot of discussion right now about, well, I'm healthy, it really should go to someone else. No, you need to take it. I used to date a philosopher that specialized in ethics, and we were talking about this the other day. It is your imperative to take the vaccine if it is offered to you. The only way that we are going to stop variants, the only way that we are going to get this under control, is if we have a high enough population getting the vaccine to stop replication, to stop variants from happening, to stop the spread. With the vaccines, we don't know right now if they will stop infection and transmission. We do know from the trials that they'll prevent you from getting sick. There's 2 different ways vaccines can work. It can either prevent you from getting sick once you're infected, which means you can still spread it potentially asymptomatically, or it will stop you from getting infected in the first place. Right now, we know that the former is what both the Pfizer and the Moderna vaccine does. There is some evidence, not conclusive, but some evidence that it does prevent transmission, infection and transmission. We're still waiting on that, which is why it's so important that after you get your vaccine, you still need to practice social distancing, and you still need to wear a mask, not only because of the potential for asymptomatic spread. Also, you need to wait 2 weeks after your last dose before your immune system is fully competent in producing antibodies. But also, you still need to wear a mask because you're not going to walk around with a giant scarlet V on your chest saying, "I've been vaccinated." We want to make sure that we have a certain level of performative prevention. I'm still wearing a mask out in public. No one knows that I've been vaccinated. I want to make sure that everyone understands that it is still important to wear a mask. We don't want there to be 2 parts of the population. Oh, you're wearing a mask, so you must not be vaccinated. We don't want to other people that haven't been vaccinated yet. It is still part of our social consciousness that we need to reinforce with each other that mask wearing is something you need to do. Just real quick up here, if anyone is afraid of allergic reactions or anaphylaxis, this is data that just came out from the CDC. There have been, in the time frame that this data was collected, there were tens of thousands of Americans that died from COVID. And yet only 31 people had an anaphylactic reaction to the vaccine. An anaphylactic reaction is highly treatable. None of these individuals died. So if you're looking at a risk-benefit analysis, if you're worried about having a reaction to the vaccine, think about not having the vaccine and your chances of getting ill and dying. I think I'd rather take the completely medically treatable, 11 cases per million doses administered risk. Right now, the vaccines are going out. I know that President Biden has 100 million doses in the first 100 days. Honestly, that's not enough. We need to double or triple that. However, 100 million is reasonable. We don't want to overpromise in public health. We want to have a realistic goal. We're currently meeting that goal for the past couple of days of 1 million shots a day. The only thing that's going to slow us down potentially is production. We don't know how many vaccines we actually have right now on stock. The CDC, a new director of the CDC, said it's something we need to figure out. Unfortunately, left over from the previous administration, left all that in shambles. Also, they are in talks to ensure that we have a continuous supply with the current vaccine makers. That's the only thing that is going to potentially slow us down right now is the vaccine supply, which hopefully we will be correcting soon. Well, the mask part that I was talking about earlier. And I now want to open up to questions and discussion.
Thank you so much, Stephanie. That was really great. Do you want to, let's see, why don't we start with the questions in the chat here?
Those disappeared.
And I will preface this with a couple of things. First of all, Stephanie is based in Florida, so she's not going to have as much information about for the local questions, but I do want to float these. I know we have a lot of informed people on this call, so we certainly can raise those questions, get Stephanie's insight from a national, public health perspective, and then open it up for a larger discussion. Also, just to add, I do have a PhD in biomolecular engineering. My dissertation was on vaccine development. So if anybody does want to nerd out on the molecular questions, I'm happy to answer those.
You're the lady for that.
Yeah. But the math modeling, that's Stephanie. So the first question we have here is about California, and that is from Gary Quemmen. Could you address if the governor's announcement today is prudent? So he just announced lifting the stay-at-home order.
I saw that. I'm not a huge fan, personally, of lifting that. I know that we all have fatigue, pandemic fatigue. I've seen this before over in West Africa with the Ebola outbreak, a year and a half into it, and people are like, I'm done. I'm done. And I know that we are on a slight downward trend in cases, but we've seen this before. We have restrictions and then we lift them and people aren't cautious enough and cases go back up. If I know that California also is not distributing the vaccines as quickly as they had hoped. And if we aren't matching and exceeding the number of vaccines administered per day, as we're seeing the number of cases, that's not conducive to slowing down the epidemic in California. So particularly not a huge fan of lifting the restrictions. I know why he probably did it. I'm just going to ask everybody to be cautious and to be careful. If you're going to go out and about, make sure that you're wearing a well-fitted mask of effective material. Masks were meant to be a stopgap. They're not 100% effective. It's one of the things I've been harping on since the very beginning. I got in a lot of trouble with some fellow epidemiologists and member of the public because I made the statement early on that masks were not going to save us, and they still aren't. But they are helping. They can assist with lowering transmission, but we need the rest of the Swiss cheese. We still need to stay distant from each other. It doesn't mean you have to be alone. If you want to sit in the front yard with a bunch of your friends, that's fine. Outside is okay, still make sure that, you're 6-10 feet apart from each other. Wear a mask if you can. Take all the precautions. So if you want to go out, not stay at home, you want to be part of society again, okay, just make sure that the rest of the Swiss cheese model is part of you going outside.
Okay, and the next question is also a California question. What do you have any thoughts about the difference in in Northern California and Southern California? Why we're seeing such a difference?
So I haven't drilled too much into this. I did read a paper the other day showing that California may, very preliminary data, may have its own variant. And that variant seems to have who needs to meet? Okay. That variant was seen in LA. So it may be accounting for some of the surge in LA, but again, that's very preliminary data. That variant hasn't been confirmed, but that may be part of it.
And the next question is from Pete, and he noticed that the case fatality rate in Mexico was up. It was over 8%, which was significantly higher. And he's wondering if it may be due to underreported attack rate.
Yeah, so this is why I'm not a huge fan of case fatality rate. I'm a bigger fan of the cases and deaths per population, which, like I was saying earlier, case fatality rate depends on the denominator of case counts. So clearly, everywhere in the world, we have a huge undercount of cases. So someone dies, they're going to get tested for COVID, they're going to come up as a case, and it's going to be not an overrepresentation, but it's going to change the case fatality rate numbers. If we had the true numbers of all cases, including those asymptomatic and those that haven't been tested yet, the case numbers are going to be much, much higher and is going to lower that case fatality rate. So I haven't delved at all into Mexico's numbers, but I'm pretty sure that probably is part of it. So again, not a huge fan of case fatality rate in this particular type of situation, more of a fan of the deaths per population.
So would it be fair to say, I mean, we're seeing a CFR of 4 times what the global average is, give or take, right? Global average being right around 2%. So we could probably extrapolate from that there are 4 times as many cases in Mexico as what are actually reported, which in itself is a huge concern. They're our neighbors. So what happens in Mexico happens in the Western United States for sure.
Well, I don't think it's necessarily that you can extrapolate that it's 4 times, but it is all of it is a concern. I actually have a classmate that didn't listen to me and went down to Cancun over Christmas break. And actually when he was down there, he said that everyone was wearing a mask, hand sanitizer was abundant everywhere. Everyone was social distancing. I have another friend in Mexico City saying the same thing. So again, I haven't looked too much into the way how they're counting cases, their testing facilities, any of that. But from at least the large cities, it seems like people are doing the prevention that they're supposed to be doing.
You probably also have to normalize for the healthcare system and so forth too. But the CFR in Italy was a little bit higher as well. And that was because the region where the disease was so prevalent was a heavily industrialized region. So I imagine there's some correlation to air quality and pollution effects on the general health of lung tissue.
Well, also, if you're thinking about Italy at the very beginning of the pandemic, we have vastly improved just in this past year, the care that we provide hospitalized patients, everyone was going on a vent in Italy at the beginning. And once you go on a vent, your survival chances drop. Just that's what venting does to you. So we have not only improved who we vent, how we vent, but we've also improved on our medications that we can use, our supportive care. So we are seeing differences in how people are dying from COVID from the beginning of the pandemic versus now.
Thank you. All right, the next question is from Rebecca. What will be the effect of the new variants or strains of COVID?
Yeah, so we're still figuring that out. Like I said, just over this weekend, things changed. We know that the UK variant is a lot more transmissible. And we've been saying that for a little bit now. Just Friday, Dr. Fauci was saying it's more transmissible, but we don't think it's more virulent, which means the capacity to cause severe disease, including death. And then the next day, Fauci said, well, actually, now we can pretty much say that, yes, it is more virulent. So it is changing. It is going to be more serious disease and deadlier. I think I saw some preliminary data that the variant in Brazil may be assisting in reinfection rates. We're still looking into what South Africa's variant is doing. Those are 3 that we recognize right now. However, good news on the vaccine front is that both Pfizer and Moderna are saying that both the vaccines are effective for the UK variant. The UK variant doesn't seem to have any less efficacy. The vaccine doesn't seem to have any less efficacy on the UK variant. Moderna said that it was a 6-fold decrease in neutralizing antibodies for the South African strain. However, because Moderna and Pfizer are both mRNA vaccines, it is a lot easier, relatively speaking, to tweak those. And Moderna is already working on a booster that will work against the South African variant. So again, good thing that we're seeing these mRNA vaccines come out after 15, 20 years of research. They're finally getting used. So we're confident that we'll have vaccines that are effective against those variants. And then this also goes back to, we need to vaccinate as many people as possible, as quickly as possible. Every time an RNA virus replicates and is transmitted to a new host, it's going to change a little bit. So we need to stop that from happening in order to decrease the probability of more variants popping up. Jenny, you have anything else to add to that?
No, I think you covered it. I'll just add that like you said, over time, the virus is naturally going to change and evolve. Most of these changes are neutral and don't give the virus an advantage. And it's only really recently with the B117 variant in the UK that we have solid data that really shows that it is more transmissible and likely more virulent as well. And we are still, this is a cause for concern, and it's a cause for us to really be more diligent about our prevention measures. I think it makes it even more striking, Gavin Newsom's decision to lift the stay-at-home order, given this kind of new threat that we're facing with these variants. But like Stephanie said, just to kind of echo, I think the big win here is that we have vaccines that work. That was never a given, and we were able to produce them at an incredible speed due to the funding of those vaccines. The reason we were able to get these out is not because we cut corners. It was because we had the money to get the data that was necessary to show that these are safe and effective. And like Stephanie mentioned, because we know these are effective, they will likely be effective against new variants. So it's really just a matter of continuing to do what we're already doing, masking, physical distancing, all of the Swiss cheese model.
Yeah, and to continue on what Jenny is saying, if anyone starts talking about how, oh, I don't know if I want to take the vaccine, it just came out too fast, I don't trust it. Not true. This technology, this mRNA technology, has been in development for years and years. Moderna was actually working on an mRNA Zika vaccine, and they were able to use that data on the COVID vaccine to help develop it. So it's not that it was all of a sudden overnight done. It's been in the works for a long time. And like Jenny said, this is what happens also when money is pretty much no object. Like, it can take years and years just to get the funding to develop a vaccine. And on top of that, a pandemic is really the perfect time to go through human trials. One of the reasons it might take years to go through a phase 3 trial is because you need tens of thousands of people in the trial to show efficacy. A vaccine could take 2 years to get that many people signed up. Pfizer and Moderna had that many people signed up in just a couple of weeks. So they were able to not only piggyback off of technology and previous vaccines that were in development with mRNA, they had the money and were in the middle of a pandemic. So they had the people ready and willing to test it out for the rest of us. And just kind of tangentially, I know we talked a little bit about the disease burden on minority populations in the US. Pfizer and Moderna both did a relatively good job really trying to recruit racial and ethnic minorities into the study. A lot of times it's heavy on white people in these studies, but they wanted to make sure that it was a little bit more equal with Black and Hispanic individuals enrolled in the trial. And part of this is due to the justified hesitancy that some minorities have towards medicine and the government in the US. I saw a picture a couple of weeks ago of a older Black pediatrician getting his first vaccine. It was a picture of him getting the vaccine, and he was holding up a sign, and it said something along the lines of that he was doing this to correct the wrongs of Tuskegee. And I thought that was a really powerful statement. I think it's very important that with the mistrust, again, justified mistrust, that some in Black Hispanic communities in the US have with medicine and medical field and science, that we have individuals that are respected in the community step forward and take the lead on this. So, yeah.
Yeah, and we have a couple more questions about vaccine hesitancy that I would like to follow up on. One is, from someone who's heard a lot of no's about, people who don't want to take the vaccine. Do you have any advice on how to change people's mind?
Yeah. That is the billion-dollar question. I've actually been working in vaccine hesitancy and anti-vaxxer research for a couple of years now, and damn, it's hard. There's vaccine hesitant people that aren't necessarily anti-vaxxers. They're just like concerned. Like I said, they may have seen things posted on Facebook or Twitter. They may have heard something. They are not quite scientifically literate enough to delve into it themselves, and they're just going to see what's on social media. So they're scared. I mean, skeptics, they have every right to be scared. They just need to be provided with correct information. With these types of individuals, I have found it best to just ask them very specifically, well, what are you scared about? What have you heard that's making you hesitant? And just really drill down into it. I actually did this over the phone the other day with my parents still live in San Diego, where I was born and raised. And I was calling them the other day, and the neighbor was talking with my mom. My mom's like, well, hey, the neighbor has some questions. She doesn't want to get the vaccine. Handed it over to the phone over to her. And she just kept, for about 15 minutes, we just went through every single concern and question that she had. And I was honest with her. She was like, well, what about, reactions? Well, yeah, sure, it's a possibility, but XYZ, taking her through everything. So that's my advice is if they're just hesitant, just drill down into why and give them resources, legit resources that can answer their questions. Now, if they're, the people that don't even vaccinate their kids against, measles, then I don't know what to say about those people. They're a little lost right now. But yeah, so that's my advice. Just try and answer their questions truthfully and keep talking to them with facts.
So we're going to do one final question, and then afterwards we have Hui Tran with us who wants to say hi to the group as well. So the last question is, can you comment on the higher mortality rate for minorities? Does it have to do with environment or social practice or something else?
That's what we still need to figure out. That's why I was trying to address a little earlier in the presentation. We know what's happening. There's a lot of different factors at play. It clearly is social determinants because we know that, biologically, we're pretty much all the same. So there's going to be a lot of need to drill down into it. I don't have the answers on that right now. A lot of people don't. We have a lot of speculation. We have a lot of potential correlation, but no exact causation right now for that.
Yeah, and I think, we don't know, we may not know the specifics for COVID-19, but it does ultimately come down to systemic racism, not personal choice. Yes. I know one thing I looked at when I was studying HIV is the higher rates in African-American women compared to white women. Black women in America were 20 times more likely to become infected. They also had better prevention practices, so more likely to have safe sex and a number of other things. So really, the reason for that discrepancy, of course, this is different, this is HIV, but the reason for that discrepancy had zero to do with personal choices. And that tends to be what we see when we do go into the data and dig a little bit deeper.
Yeah, I mean, like I was mentioning earlier, essential workers, low-wage workers, they're going to have more contact with the public. They didn't have the luxury, low-wage workers didn't have the luxury of sheltering in place at home for months at a time. They had to be out there interacting with the public, unfortunately.
Well, thank you very much, Stephanie. This was really fantastic. I really appreciate you taking the time to come speak with our members. And I personally have been incredibly burnt out by this experience, and to do science communication, you know, through your podcast and Facebook page and coming here tonight on top of everything else, I really, truly applaud you for that. So thank you.
Thank you for having me. I'm happy to answer questions and talk with anyone that will listen.
And so I'm going to go ahead and turn it over now to Hui Tran, who is joining us tonight.
Good evening, everybody. I hopped on in the middle of Stephanie's presentation, and that was some good information. My name is Hui Tran, for those I haven't had a chance to meet. Excuse me. And you know, I wanted to make sure I came back in tonight to kind of keep you all updated on what I'm going as well, and definitely to hope that the club will continue to support my candidacy. The election around the primary last year didn't go the way we wanted it, but that doesn't mean that the work has stopped. Over the past year, I've actually really been focused on COVID-19. The great work done by people like Stephanie and honestly Jenny helping to spread the information out too. I hope you don't stay burnt out, because we keep needing people who are going to do that. It's been critical. And that work actually has moved me to be more involved in politics as well. And part of the reason, even more so, I guess, part of the reason for that though is because over the past year, it's really felt like doing simple things, like just trying to take care of the people around us, is now a political act. Right. And where this kind of connects is that I'm running to be a voting member of the Central Committee, and I'm hoping to get the club's support. I'm also, full disclosure, I'm also running to be a voting delegate to the state party as well, under the people-powered progressive slate supported by Assembly member Alex Lee. The work that we've done in the past year has really been, it's really no blurring the lines between political work and humanitarian work. You know, over the past year, I've really focused on getting COVID-19 information translated, disseminated, and shared out into different communities in different languages. And that also includes working with the unhoused. Kind of crazy, because this is the kind of work that I would do on a normal basis, and I wouldn't have considered that like political at any point. But because of just the wildness and the craziness of the past 4 years, it feels like a revolutionary act to just simply care about the people around you. And part of the reason that motivated me to want to get involved in the Democratic Party was the January 6th insurrection that we saw in DC. What was particularly hurtful for me about that was simply seeing the sheer number of Vietnamese flags, the yellow flag with the 3 red stripes, flying in that crowd. For Vietnamese folks, that symbol is very important. That one symbol encapsulates why the majority of Vietnamese people who live overseas, away from Vietnam, are where they are. And it was flown next to symbols of hate and racism, and I and many other Vietnamese Americans who saw that just gobsmacked. And that kind of led to a lot of conversations around what we need to do to be more involved. So I'm running to the Central Committee to open up that door. We want to get more Vietnamese Americans involved in the Democratic Party. Unfortunately, the Republican Party has done a lot of good work over the past decade, really building in a base among the Vietnamese voters, but we're going to fight that now. And I hope to do that from the Central Committee seat. I'm also running as a progressive, an advocate, and an organizer, so that we can bring in some strong, solid grassroots values into the Central Committee, build up on that foundation, and make sure that we don't go back to what we saw in the past 4 years. I want to be here. I hope to get the club support. Y'all can answer any questions as well if you have any, but I also don't want to take up too much of your time if you guys have very important agenda items to consider, like talking about COVID-19. That's it, and I hope to get your support.
All right, thank you, Hui. And we are just past time. I want to close out by, well, first I want to open it up to any other ADEM candidate that would like a minute to speak, and then we'll officially close. I will stay on the line if anybody wants to continue the discussion afterwards, but I do want to be respectful of everyone's time for those who are looking to end at 8. And so are there any other ADEM candidates on the call? Okay. All right. Well, I hope that everybody can join us next month at our next general meeting. And with that, the general meeting for the Silicon Valley Democratic Club is officially closed.